Hi, thank you for joining us on another Medical Physics Minute, where we take a look at timely topics related to quality management and patient safety in radiation therapy. My name is Jason. I'm one of the clinical physicists on the global team here at Sun Nuclear. Today we're going to look into a timely publication on in vivo efficacy. This group out of the Iridium Netwerk in Belgium has published and presented on many topics utilizing the perfraction offering within SunCheck Patient from Sun Nuclear. The title today is The Use of In Vivo Dosimetry to Identify Head and Neck Cancer Patients Needing Adaptive Radiotherapy. This group investigated the sensitivity of EPID-based in vivo dosimetry to detect patients that require adaptive radiotherapy. It's well understood that there are daily variations in anatomical position in head and neck cases, often due to weight loss, tumors that shrink, postoperative changes during the course of treatment. It's not as easy to determine the dosimetric impact of these daily anatomical variations. The study quantified the effect of anatomical changes and clinical dose parameters of head and neck patients. In vivo dosimetry using perfraction is sufficiently sensitive and specific to detect errors without an unwieldy number of false positives. This is another tool in the toolbox to help with adaptive decisions. Their methods are, it's a retrospective study, 182 patients, 3 different groups, ABC, laryngeal cases, postoperative RT cases, and primary RT with elective nodal involvement. They used a cumulative EPID transit dosimetry measurement using perfraction in SunCheck Patient, where they looked at the number of failed fractions and where did they occur relative to a clinical trigger for adaptive therapy. Plans and replans were compared by recalculating CT sim data. CTs were taken initially and then upon replanning. Clinical volumes were used to evaluate whether adaptation was necessary. This first table shows the percent volume reduction as a clinical anatomical endpoint, both targets and OARs, the parotid glands. It also shows weight loss and a change in body contour. So these anatomical endpoints also were correlated with the number of failed fractions. When there was a presence of a failed fraction, these anatomical clinical impact endpoints were larger. Also, dosimetrically speaking, target coverage, mean dose to the parotids, max dose to the spinal cord, these were also tracked and quantified. And in the presence of a failed fraction, these discrepancies were larger. So the presence of failed fractions had a strong correlation with both anatomical changes and with the dosimetric impact to the targets and the OARs. These EPID-based in vivo dosimetry triggers were found to correlate with larger dosimetric and anatomical changes, the cutoff value being 95% or 95.2 for the old or new generation machines. They utilized these EPID-based triggers are 3%, 3 millimeters global normalization threshold of 20%. Failed fractions were also observed before the clinical indications triggered the actual evaluation of adaptive radiotherapy. Interestingly, they found there was no statistically significant association between weight loss and dosimetric parameters. But they did find that the change in body contour, that anatomical change, was found to be significantly associated with the mean dose to the parotid gland. As you lose body contour, as you lose weight, you end up having the parotids are closer to the targets. Their conclusions identified that this clinical endpoint, this EPID-based clinical endpoint, when combined with cone beam CT during the first 3 fractions and weekly thereafter, it does have adequate information about anatomical changes that can help to trigger adaptive radiotherapy. Some of the clinical indications, such as general weight loss, the mask being too tight, the mask being too loose, these trigger an evaluation of an adaptation to the plan. But this automated dosimetric analysis, these triggers 95, 3, and 3, can be a helpful tool to support the decision-making along with these clinical indications. EPID-based in vivo dosimetry was found also in the conclusion to eliminate unnecessary replans that are otherwise based only on human judgments related to imaging and other clinical factors. The discussion in the discussion section, they say perfraction has a strong ability to discriminate between dosimetrically acceptable and unacceptable patient plans. So as in vivo utilization increases around the globe, TG307 was recently published, we look forward to more studies showing the efficacy of automated in vivo analysis If you want to learn more about this publication or any other solutions from Sun Nuclear, request a physics demonstration with your Sun Nuclear physics team. Thanks very much.